section we will be dealing with the pathophysiology, the different clinical features as well as the screening and treatment of diabetic retinopathy, which is a very high yielding topic. Okay, so let's begin with the diabetic retinopathy. This diabetic retinopathy can occur in both the diabetes, that is your type 1 diabetes, insulin dependent diabetes mellitus, as well as the type 2 diabetes, that is non-insulin dependent diabetes mellitus. Okay. Now, when you compare between the two, which one is more common? It is non-insulin dependent diabetes, which is actually more common, and that is why this will show the complications, because as I always say, the thing which is less common will always show more of the complications. So, non-insulin dependent diabetes mellitus is more common, while the insulin dependent diabetes mellitus is more severe and therefore shows more of complications, and therefore diabetic retinopathy is more common in the type 1. It is more common in the type 1 diabetes mellitus. Okay. Now, what are the other risk factors? As I always say that risk factors are important. So, let us see the risk factors of the diabetic retinopathy. The other risk factors for this diabetic retinopathy are, like, we have female. In females, we have more incidence of the diabetic retinopathy, like a male having diabetes and a female having diabetes. So, it is always more chances that a female having diabetes will develop the diabetic retinopathy, especially if she is also having the hypertension, or if there is a pregnancy or the anemia. So, these are the other risk factors which can actually lead to the diabetic retinopathy. The type 1 diabetes along with the female gender, along with the hypertension, along with the pregnancy and along with the anemia. Okay. Now, the next important thing, what is the most important factor? What is the most important factor for the diabetic retinopathy? This is again a very importantly asked question. What is the most important factor of the diabetic retinopathy? It is actually the duration. That is duration of the diabetes mellitus. It is the duration of the diabetes mellitus which forms the most important factor for the diabetic retinopathy, especially if the duration is more than 10 to 12 years. More than 10 to 12 years, a person having diabetes from a very long period will have maximum chances for the development of the diabetic retinopathy, and it is not affected. It is not affected by the acute levels of the blood sugar. It is actually not affected by the acute levels of blood sugar. So, if acutely a patient develops a very high amount of sugar, maybe 300, 400, that does not mean that he will develop the diabetic retinopathy next morning. He always requires a long period along with the diabetes, hyperglycemia for a very long time, especially for about 10 to 12 years. Only then he will be expected to develop this diabetic retinopathy. Okay. Now, another important thing is that it is actually a microangiopathy. It is actually a microangiopathy, means the diabetic retinopathy is a microangiopathy. So, this will be affecting the smaller blood vessels, that will be the capillaries along with the arterioles and along with the venules. The capillaries along with the arterioles, along with the venules will form the majority of the blood vessels to be attacked by the diabetic retinopathy, and this is again an important fact because it is actually a microangiopathy, means it affects the smaller blood vessels. That is why it actually leads to the maximum ischemia. There is maximum ischemia. Now, because we have maximum ischemia, therefore, this will lead to the maximum hypoxia, and maximum hypoxia will lead to the release of the vascular endothelial growth factor, and this vascular endothelial growth factor will actually lead to the angiogenesis, that is your vascularization, neovascularization. So this is how actually vascularization becomes important in the diabetic retinopathy. Why it is actually the most common cause of neovascularization, most common cause of TRD, most common cause of neovascular glaucoma, because actually it is a microangiopathy and it is affecting the small blood vessels. Because it is affecting the small blood vessels, that is why neovascularization is most important in cases of diabetic retinopathy. Okay, now coming to a study. The study which is done for the diabetes, the most popular is ETDRS study. ETDRS study, this is recently asked in AIMS November 2019. AIMS November 2019, that what is the name of the disease for which this study is done? It is a diabetic retinopathy. The name is the early treatment diabetic retinopathy, early treatment diabetic retinopathy study. Early treatment diabetic retinopathy study. We have other also, like we have diabetic retinopathy study, or we have diabetic retinopathy vitrectomy study. This is the diabetic retinopathy, diabetic retinopathy study, or we have one more, that is your diabetic retinopathy, diabetic retinopathy vitrectomy, diabetic retinopathy vitrectomy study. So these are several studies which are actually done for the diabetic retinopathy, and out of these, this one is actually the most important. The most important is the diabetic early treatment diabetic retinopathy study, and based on this we have got 4 stages of the diabetic retinopathy. Now we have got 4 stages of the diabetic retinopathy. So let's begin with the first one. The first stage is the earliest stage. This earliest stage is NPDR. It is NPDR, which means that it is non-proliferative. This is the non-proliferative stage of diabetic retinopathy. Now, can you see the name is non-proliferative stage. So, here you do not have any proliferation. This is the earliest stage of the diabetic retinopathy and the earliest sign. The earliest sign of this stage is actually the microaneurysms. It is the microaneurysms. Not only the earliest, but it is also the hallmark sign, most pathognomic sign, the characteristic sign. And why we are getting these microaneurysms? The microaneurysms that we are getting is due to the loss of the pericytes. We are getting the loss of the pericytes from the walls of the capillaries. So, due to the loss of the pericytes from the capillary walls, there is actually the dilatation of the capillaries. So, you are getting very pinpoint hemorrhages. You are getting very small hemorrhages. These are the pinpoint hemorrhages that you are getting in the microaneurysms. The microaneurysms is the earliest sign. It is also the hallmark sign, as well as the earliest sign of not only NPDR but also the diabetic retinopathy as a whole. Why I am saying that not only NPDR but also the diabetic retinopathy as a whole? Because NPDR is also the earliest stage of diabetic retinopathy. So, whatever is the earliest sign of the NPDR will become the earliest sign of the diabetic retinopathy as a whole also. Now, apart from these microaneurysms, we are also getting the deep hemorrhages. The deep hemorrhages are also called as dot and blot hemorrhages. Deep hemorrhages or the dot and blot hemorrhages. Like we get the superficial hemorrhages in the hypertension retinopathy, similarly we get the deep hemorrhages in the diabetic retinopathy. Now why they are called as deep? Because they are going into the deeper layers. In the hypertension retinopathy, the hemorrhages were just spreading superficially only in the superficial layers. They were not going to the deeper layers, and that is why their shape was flame shaped. But here the hemorrhages are not only spreading horizontally, but they are also spreading vertically. That is why they are taking the shape of a circle. So these hemorrhages are called as dot and blot hemorrhages. So not only they are forming the dots, they are like this. The bigger ones are also there, and as their size gets big, they become a blot. Now can you see here, we have got the pinpoint microaneurysms also, we have deep hemorrhages also in the form of dots as well as the blots. So we have got multiple sizes of hemorrhages that will be present. So whenever you are getting a fundus pathology and you are seeing the multiple size of the hemorrhages, the first instinct is diabetes. Also remember, D for the diabetes, D for deep, and D for dot and blot. While you were getting superficial in cases of the hypertension, superficial hemorrhages, S for superficial and S for soft exudates. Here in the diabetes, D for diabetes, D for deep, and D for dot and blot hemorrhages. Okay. Now, in which layer you are getting this? This is again an important thing. In which layer you are getting both of them, that is your microaneurysms as well as your dot and blot hemorrhages. Both of them are found in the inner nuclear layer. Both of them are actually present in the inner nuclear layer. While the changes of the hypertension retinopathy, were actually found in the nerve fiber layer. The changes of the diabetic retinopathy, including the microaneurysms and the deep hemorrhages, are present in the inner nuclear layer. Now, if you remember, I told you about the open. Okay, now open means the outer plexiform and the inner nuclear layer, out of which this inner nuclear layer is showing you the microaneurysms as well as dot and blot hemorrhages. And I told you that opens a gate for retinal diseases, and most of the retinal pathologies are actually found in open. Now you are left with this outer plexiform layer. So this outer plexiform layer is showing you the third thing, and that is your hard exudates. So another important thing that you get in this patient of NPDR is actually the hard exudates. They are found in the outer plexiform layer. They are found in the outer plexiform layer. You can remember it by the hop. The hard exudates are found in the outer plexiform layer. And how do they actually look like? They are lipids and the lipoprotein deposits. Sometimes they are also arranged in a ring-shaped fashion. So they are actually lipids, and they are the lipids as well as the lipoprotein deposits, lipids and the lipoprotein deposits, which are found in the outer plexiform layer. And the ring pattern, when they are arranged in the ring pattern, then they are also called as succinate. Then it is called as succinate retinopathy. Then this is also called as the succinate retinopathy. So what are actually hard exudates? What is succinate retinopathy? How actually the hard exudates look like? What are the changes that you are getting in NPDR? You are having so many changes in NPDR, but what you are not having is the proliferation. That is why it is called as non-proliferative stage of diabetic retinopathy. Along with this, we also have the IRMA. Now, what is this IRMA? IRMA means we have intraretinal microvascular. Intraretinal microvascular abnormalities. So in patients of NPDR, though I am not having any of the proliferation, but I may have small microvascular abnormalities in the form of the AV shunts, in the form of the arteriovenous shunts. This is different from the neovascularization along with the venous changes. I can also have the venous changes, like we can have the beads or we can have the loops, okay, in the veins, and along with this I can also have the retinal edema. Edema in the retinal layer can also be present. Now can you see there are so many changes that have actually taken place in the patient of NPDR except for the proliferation. And when can I say that this patient is actually having severe NPDR? I can say that this patient is actually having severe NPDR when there is 4-to-1 rule applicable. For this we have a rule called as 4-to-1 rule. So I can divide whole of the fundus in 4 quadrants. Suppose I have this as the retina, okay, and I have divided this retina into 4 quadrants. These are the 4 quadrants that are actually present in the fundus. Now they are saying what is the criteria. What is the criteria actually? The criteria says that either you get 4, means either we have 4 quadrants, all 4 quadrants showing the microaneurysms. If all 4 quadrants are showing microaneurysms, then it is 4. Then we have the second one, right? Second criteria is 2. So at least 2 quadrants. If at least 2 quadrants are showing the venous changes, okay, and then we have what you call as third, that is at least if one quadrant is showing the Irma. So any of this, either this or it is this. If any of these criteria are present, means if the 4 quadrants, all 4 are showing you microaneurysms, or at least 2 quadrants are showing you the venous changes, or at least 1 quadrant is showing you Irma, you will say that this is a severe NPDR, and any time this stage can actually go into the PDR. Okay, now we will try to see the changes that can actually take place in a patient of the NPDR. See, this is the first change that can actually take place. Can you see the normal capillaries? This is how the normal capillaries look like, and you can see here the pericytes are present, and here we have got the acellular capillaries with the parasite ghost. Now slowly and gradually there will be formation of a microaneurysm. See, there will be the total absence of the pericytes here, and thus a microaneurysm is formed that will be showing you the dilated capillary wall. So this is how actually the microaneurysm will look like. Okay, now we will try to see the fundus. Okay, now if we see the fundus picture of the diabetic retinopathy, what I told you, that you must be having the different size of hemorrhages present in the fundus. Now can you see here, we have got very small ones also, which are just the dots. So we have got the very pinpoint ones also. These will be your microaneurysms, which are very small. Then we have dots, right, and then we have got the blots. So we have microaneurysms, that is your pinpoint hemorrhages, then we have dots also, we have blots also, then you can see the hard exudates, but there is no proliferation. So very clear cut I can say that this is actually the NPDR stage of the diabetic retinopathy. Okay, now see here, I have used a labeled one, because many a times we keep on explaining you, but you exactly don't know what we are talking about and what is optic disc, what are hemorrhages. So in order to give a very clear cut view here, can you see here, we have, this is the optic disc, right, and over the optic disc you have got 2 vessels, one is a darker one and another is the lighter one. So darker one is always the venule. Can you see this dark one is the venule and the light one is your arteriole. And now you can see very small hemorrhages. So this will be your microaneurysms. Then you have got other hemorrhages, and then you have got the smaller exudates. Like you saw in hypertension retinopathy, they were very large, fluffy, lordaceous, resembling the balls of the cotton wool. That is why they were called as the cotton wool exudates or the soft exudates. But these exudates are smaller and they are darker in color because these are actually the lipo proteins or the lipids, while the cotton wool spots were actually the neuronal deposits. So I think both our pictures are very different. Why I am trying to compare both? Because mostly you get the fundus pictures of the hypertension retinopathy and the diabetic retinopathy, like you got this year in JIPMER also, and there was a feedback that we got the similar images from the class. So I wanted to show you the same images, and I want that here the confusion that whether it is diabetes or it is hypertension should not be there, because both of them are quite different. Okay, now let us see here. This is a image which is showing you two things. One is the edema and another is your venous beading. Now what is actually beaded? Can you see here we have a beaded structure that is present in the vein. This is clear cut called as the venous beading. Like on the other side you are able to see the small area that is marked by the arrow. This is actually a AV shunt, a arteriovenous shunt. So the small branches which are actually coming out from the major blood vessels, they are showing abnormal communication between an artery and a vein. So can you see this is very different from the neovascularization, where we actually have the proliferation of the new blood vessels. So this was the venous beading and the edema. Now here again I have tried to show you the beaded structure of the vein. Can you see here? There is a beaded structure of the vein, and here there is a very small edema, very small arteriovenous communication that is showing you the communication between an artery and a vein. Okay, then another image. This is showing you the very beautiful loop that is formed in the veins. This is actually the venous looping. This is called as the venous looping. So we can have beading, or we can have segmentation, we can have looping, we can have edema. There are so many changes that can take place in the NPDR stage. Now how does it get differed from the PDR stage? When I say PDR, proliferation, proliferation means actually the neovascularization, and this neovascularization can occur both over the optic disc as well as elsewhere. Elsewhere means along the major blood vessels. Now try to concentrate on this image. Can you see there is lot of new vessels? A network is actually present over the optic disc. This is your NVD, neovascularization at the optic disc. Now if you try to follow these blood vessels, the blood vessel is actually going like this, and again it is showing you neovascularization. So this is actually the neovascularization elsewhere. So can you see how we can actually differentiate the NPDR stage from the PDR stage? Now try to see both. On one hand I am having the NPDR stage, and on one hand I am having the PDR stage. The PDR stage is actually showing you lot of abnormal blood vessels over the optic disc, but other features are same, that is your microaneurysms, your dot and blot hemorrhages, your hard exudates, your edema, other things will be same. The only difference can you see between the two picture is the presence of this neovascularization over the optic disc as well as the other areas here. So I can say clearly that this is actually, this one is your NPDR and this one is actually your PDR. Okay, so let us try to see now. So now let us try to see the second stage of the diabetic retinopathy, and that will be your PDR stage, the PDR stage. The PDR stage means it is the proliferative diabetic retinopathy. Now as the name indicates, what is the main thing that you are getting here? The main thing that we get here is the neovascularization. So neovascularization is the hallmark. Now can you see the difference? While the hallmark of NPDR or the Diabetic retinopathy as a whole was microaneurysms. For the PDR stage, neovascularization is the hallmark, and this neovascularization can occur at two places. We can have the NVD or we can have NVE, neovascularization at the optic disc, neovascularization elsewhere. So we can get here neovascularization. This is actually the neovascularization at the optic disc. Okay, D means the disc here. Okay, while the second is neovascularization elsewhere. Now, what is the meaning of elsewhere here? Elsewhere means along the major, this is along the major blood vessels. So, when it is found at the optic disc, it is neovascularization at the disc, and when it is found along the major blood vessels, that is actually called as NVE, and it is this actually which is present for the recurrent vitreous hemorrhage. This is responsible for the recurrent vitreous hemorrhage in the elderly. So, what is the most common cause of the recurrent vitreous hemorrhage in the elderly people? It is actually the proliferative stage of diabetic retinopathy that is most of the times responsible for the complications in the diabetic retinopathy. It can be TRD or it can be neovascular glaucoma. Then you should be knowing the earliest sign, you should be knowing the hallmarks of both NPDR as well as PDR. Then slowly and gradually we can reach to the third stage. The third stage of diabetic retinopathy is the diabetic maculopathy. This is the diabetic maculopathy. Now, this maculopathy can occur. This can occur after both NPDR or it can occur after PDR. So, it can occur post NPDR also or post PDR also, and that is why many books says that it is stage 2 and many books says that it is stage 3. You should know that actually the maculopathy can take place after any of these stages, while PDR will always occur after NPDR. A person, if he is coming directly to you in the PDR stage, means that he has not come to you, he has not visited to you during the stage of NPDR, but this is not a possibility that the person does not have the stage of NPDR. So, he must be having NPDR, now it has turned into PDR and now he has come to you. Okay. Now, what is actually the maculopathy? Maculopathy means the patient has started showing the involvement of the macula. If the patient is having the pathology over the macula also, if there is involvement of the macula, then I will say that this is the stage of diabetic maculopathy, and in fact it is this diabetic maculopathy which is the most common etiology of the diminution of vision in the diabetic retinopathy. What is the most common cause of diminution of vision in the patients having diabetic retinopathy? It is the diabetic maculopathy. Now, there is a term called as clinically significant macular edema. There is a term called as clinically significant macular edema. Now, what is the meaning of this clinically significant macular edema? I can say that this person who is having diabetic retinopathy with macular edema is significant. It is significant when, what is the criteria? Now, it is called as significant when number 1, it is found at the macula. If it is found exactly at the macula, it is significant. Or number 2, it can be 500 microns from the center of the macula, or if it is found 500 microns just from the center of the macula, And the third criteria is that the increased retinal thickness. The increased retinal thickness is at least 1 disc diameter, that is 1.5 mm. So there are three criteria for saying that this macular edema is actually clinically significant. It should be at the macula, or it is 500 microns from the center of the macula, or the increased retinal thickness is at least having 1.5 mm thickness, that is 1 disc diameter. Then I can say that this patient is having clinically significant kind of macular edema. Alright, now coming to finally the fourth stage. In the fourth stage, this is called as end diabetic eye disease. Okay, now this is a stage of advanced diabetic retinopathy where you will be started having the complications. So if the patient is having complications which are mainly due to the recurrent vitreous hemorrhage, like it can be the tractional retinal detachment, or it can be the neovascular glaucoma, then I can say that this patient is having advanced diabetic eye disease. A patient can have this tractional retinal detachment. The most common type of RD that you are getting here is the tractional retinal detachment. Also, it is the most common etiology of the neovascular glaucoma. This is the neovascular glaucoma. This is called as the neovascular glaucoma. So these are the 4 stages of the diabetic retinopathy. Now coming up with some of the visuals which are very important, and they have been recently asked also in your exams. Okay. Now can you see here, this is actually the FFA picture. Fluorescein fundus angiography. When you do the angiography, as we discussed before also, that you see a grayish hue due to the presence of the choroidal fluorescence, and the whitish areas are actually the blood vessels where we have pooling of the dye. Now can you see, we have got small areas which are glittering over the fundus. These small areas which are actually glittering over the fundus are actually the microaneurysms. These are the microaneurysms which are actually glittering all over the fundus, because they are the dilated capillaries which is showing you the pooling of the blood. And then you can also see here, this is the area of Irma. This is the area of the Irma where there is a communication between the artery and a vein. So because I have the Irma, because I have the microaneurysm, so I can say this is the NPDR stage of the diabetic retinopathy. Okay. Now focus on this one. Now this is again showing you lot of the microaneurysms. Okay, so I have got this microaneurysms, but can you see, apart from this microaneurysms, I can also see the pooling of the dye, like here. So there is a lot of pooling. This pooling is occurring or there is a leakage, due to which I am getting lot of white area. So this is actually your neovascularization. Okay, so you are getting, that means you are getting the ischemia, and due to the ischemia I am getting the VEGF factor, due to the VEGF I am getting the neovascularization. So this blackish area that you are getting here, there is an enlargement of the foveal avascular zone. Now this increase in the foveal avascular zone shows that actually what is happening here, there is actually the ischemic maculopathy. This is showing you ischemic maculopathy. So because we were having lot of ischemia in the macula, we were having the ischemic maculopathy. Due to this, we were having the neovascularization, and microaneurysms will be present in both, because it is actually the hallmark of the diabetic retinopathy as a whole. So in this way, you can see the FFA findings. Now see here, this is a picture that is actually showing you the vitreous hemorrhage. Okay, now because of this vitreous hemorrhage, right, the tangential bends are formed. the tangential bands are formed in the vitreous cavity, and they can actually lead to the tractional retinal detachment. So this is actually a picture showing you the tractional retinal detachment when there is a lot of vitreous hemorrhage in the cavity. Slowly and gradually it will organize, right? It will organize. There will be a dense vitreous hemorrhage. So dense and the old vitreous hemorrhage will form the vitreous bands, and this vitreous bands will actually lead to a tractional retinal detachment. Okay, see, this is again lot of vitreous hemorrhage. This is again lot of vitreous hemorrhage which is actually taking place in a patient having the diabetic retinopathy. Now, because you have seen that there are so many complications that are taking place in the diabetic retinopathy, it's a high topic, and it remains a major cause of the blindness also. How should we actually screen for this patient? So, let us try to see the screening. The screening of the diabetic retinopathy. Now, for the screening, what I can do, I can actually divide these patients in the type 1 diabetes mellitus, right, and the type 2 diabetes mellitus, type 1 diabetes mellitus and the type 2 diabetes mellitus. In the type 1 variety, what you are doing, you can actually start the screening, within the 5 years of the diagnosis. Within the 5 years of the diagnosis. Now, what is actually the reason for this? Why you have to start within 5 years? Because actually insulin dependent diabetes mellitus is a young onset diabetes. It is diagnosed early, and you know the most important factor for the development of diabetic retinopathy is actually the duration. So because here the patient actually has not lived with so many years of diabetes, so still you have time of 4 to 5 years within which you can start the screening. But if you see this type 2 diabetes, which is actually the maturity onset diabetes, the patient has already lived with so many years of diabetes. Mostly this diabetes is actually discovered due to some of the complication. Complication occurs only after 10 years. So this means patient has actually lived with at least 10 years of the diabetic retinopathy, and that is why you have to start the screening actually immediately. We have to start the screening immediately, or it can be as soon as possible. As soon as possible or immediately, as early as feasible, because you don't want to waste further time before doing the screening. Why? Because the changes of the diabetic retinopathy are actually irreversible. So whatever amount of vision loss has already occurred in the patients of diabetic retinopathy can't be reversed. We can only control the complications, but we cannot reverse the vision. That is why the screening is a must. So this is again a very important potential question that can be asked in your exam. When should we start the screening? Okay. Now, another important thing is the diminution of vision. The diminution of vision that takes place in a patient with the diabetic retinopathy, again I can divide this into two parts. Okay, we can divide this into two parts, like one is your sudden vision loss and another we have is the gradual vision loss. The sudden vision loss and the gradual vision loss. Now, in this sudden vision loss, again we have the two things, whether I am talking about the NPDR or diabetic retinopathy as a whole, or I am asking you about the PDR. Okay. Now, if I am asking you about the NPDR, what is the most common cause of sudden vision loss in NPDR, then your answer will remain the maculopathy. Your answer will remain the maculopathy. So, in other way I can say the most common cause of the sudden vision loss in the NPDR is the maculopathy, right? While the most common cause of sudden vision loss in PDR. In the PDR, it can be the recurrent vitreous hemorrhage. It can be recurrent vitreous hemorrhage. Similarly, if I am talking about the gradual vision loss, the gradual vision loss which is occurring in the patient of the diabetic retinopathy, now What can be these causes? It can be the number one, the tractional retinal detachment. Tractional retinal detachment, or we have studied about the cataracts. Cataracts are very common in the diabetic people, so it can be due to the cataract. And number three, it can be diabetic retinopathy itself. Even the changes that are occurring in the diabetic retinopathy can itself also cause the gradual vision loss. So likewise, now you have got this flow chart that will help you to solve so many MCQs regarding the diminution of vision in a patient of the diabetic retinopathy. First, see whether it is sudden, whether it is gradual, whether it is NPDR, whether it is PDR, and you will get the answers. They can ask you the type of RD, the type of cataract, then they can also ask you the all except MCQ about this gradual vision loss. Now we come to the treatment of the diabetic retinopathy. The treatment of the diabetic retinopathy. Now, before we actually start treating the lesions of the diabetic retinopathy, we start giving treatment, the first thing which is very important is the strict metabolic control. Strict metabolic control of the blood sugar. The strict metabolic control of the blood sugar is the most important thing that we can do for the patient, because what is happening actually, the lesions are actually directly proportional to the hyperglycemia, and the lesions that you are getting in diabetic retinopathy are formed due to the lesions are formed due to the glycosylated end products. So because the glycosylated end products are forming the lesions, therefore I can say that the first thing that we should do is the strict metabolic control. Then coming to the second thing. Now second thing that we can do is the PRP. PRP for the existing lesions, the lesions that have already been formed in the patients of diabetic retinopathy. For this we can do the pen-retinal photocoagulation. Pen-retinal photocoagulation. Now, what is this? It is pan-retinal photocoagulation. So, what we are doing? We are actually giving the laser spots. So, laser spots are given in whole of the retina, and the whole of the retina requires about 2000 to 3000 laser spots in order to be covered. Okay. Now, because you people tend to read Khurana, therefore, I will say one thing here. If you see Khurana here, okay, in Khurana, they have mentioned 1200 to 1600 spots, which is not correct. Because if you see generally how many spots we give about 1500 to 4000 spots. Okay, it can be sometimes 6000 or even 8000. Okay, so basically it is the starting point. We can start roughly between 1200 to 1600, but anyhow you cannot cover whole of the retina, you cannot cover whole of the retina with these spots. So that is why I have chosen this value. This is from the Parsons, which is obviously more logical. You require at least 2000 to 3000 laser spots in order to cover whole of the retina. Okay, now if you see each laser spot, okay, each laser spot, the size of each laser spot is about 500 microns, which is given for a duration of 0.1 second. Okay, so total number of spots, the size of each spot, the duration of each spot, and then we have the distance. Then we also have the distance between the two laser spots. The distance between the two laser spots. The distance between two laser spots is again 500 microns. Now, this is very strict. Why? The reason is that because you are burning the blood vessels in that area and you are increasing the avascularity. That is why you have to be very, very clear that how many spots you have to give, what is the size, what is the duration, right? Suppose this is the retina here and I want to give the laser spots. So what I am doing, I am creating this okay, and when you give these laser spots, actually that area is converted into a blind spot. So see, I am giving 500 microns laser spots at a definite distance of 500 microns only, right? And can you see, I am maintaining the distance, and I will leave the area which is near the optic disc, okay. Suppose this is the optic disc, so you will leave this area so that the central retina is not burned. So can you see now, when you have so many spots given in the periphery, when you are covering all of the periphery, and each of this is converting into a blind spot, finally you will get a ring shaped scotoma. So this will also come under the DD of the ring scotoma. It will also come under the DD of the ring shaped scotoma that you are getting in the fundus. Whole of the fundus is covered with the laser spots. Now you will be wondering that why then we are giving this laser photocoagulation, if at all it is not reversing the vision is not coming back and it is converting them into the blind spot. The reason is to prevent the complications, to arrest the complications, because all the complications are mainly taking place due to the vitreous hemorrhage. So in order to stop this vitreous hemorrhage, actually I am giving this pan laser photocoagulation, okay. Now coming to the third step, what else we can do? We can also give the anti-VEGF agents. Now, as we discussed that mostly all the complications are actually taking place due to the vitreous hemorrhage, due to the bleeding from the blood vessels. So what can I do? I can actually reverse this neovascularization by giving the anti-VEGF agents, because we know the main factor which is actually responsible for the angiogenesis is VEGF. Now when to actually administer this? You can give in PDR, and you can also give this in severe NPDR, means when the patient is having very severe variety of non-proliferative diabetic retinopathy, even that time also we can start with this anti-VEGF agents. You need not actually sit and wait for the PDR to occur, okay. Now what are the names of these agents? Like we have the bevacizumab. We have bevacizumab, which is available by the name of the Avastin, okay. Then we have got the ranibizumab. This ranibizumab is available by the name of the Lucentis, and then we also have the Macugen, okay. That is actually pegaptanib. So these are the different VEGF agents, and I must say they are actually creating a revolution in the field for the treatment of diabetic retinopathy, because by giving them you are not only arresting the neovascularization, you are also preventing the neovascularization, you are also arresting the bleeding from this. So this is again a very important thing in the treatment of this diabetic retinopathy. Then coming to the fourth thing, we can also give the intravitreal. We can also give the intravitreal triamcinolone. We can also give the intravitreal triamcinolone. Now, what is this intravitreal triamcinolone? It is actually the injection. We can also give the intravitreal injection of the triamcinolone, which is actually a steroid, okay. Now, if I feel that the patient actually has the macular edema, okay, and especially if it is clinically significant macular edema, then I should start with the intravitreal injection, so that I may be able to resolve this macular edema. I can limit the maculopathy, because you know that maculopathy is actually the most common cause of the diminution of vision in the patients of the diabetic retinopathy. And then finally I have what you call as the PPV, that is your pars plana vitrectomy. This is the pars plana vitrectomy. Now what is the meaning of this pars plana vitrectomy? Pars plana is actually the posterior smooth part. It is the posterior smooth part of the ciliary body through which we are doing this vitrectomy, that is we are doing the vitreous aspiration. So why actually this vitreous aspiration is important of the fibrous bands. Now why you want to remove these fibrous bands, which because it can lead to the tractional retinal detachment. So in order to prevent this tractional RD, what can I do? I can actually do the aspiration of these tractional bends. Now let us try to see the visuals of these things. Now like I showed you before also, this is actually a kind of tractional retinal detachment that is actually taking place due to the tangential bands. Okay. Now then we saw the lot of vitreous hemorrhage that is actually present in the cavity. It can be due to the PDR stage. Okay. Now this is the image which is showing you pan-retinal photocoagulation. This is a stage which is showing you the pan-retinal photocoagulation. Can you see here we have given so many laser spots, and the laser spots which are given here, they will be having the size of 500 microns, and the distance between these two spots will again be 500 microns given for a duration of 0.1 second. So this is how we have left this area, which is the optic disc area and the macular area, that is spared, and we have tried to cover whole of the retina with the laser spots. Okay. Now this is actually the intravitreal injection. This is your intravitreal injection of the triamcinolone. So for the clinically significant macular edema, we have tried to give this steroid injection inside the vitreous cavity. Okay. So this was all about diabetic retinopathy. This is a very high-yielding topic, giving you lot of MCQs, lot of insight in how the fundus looks like, what are the different layers that you are getting the pathology in, what are the hallmarks of NPDR in PDR, how to read the FFA along with the intravitreal injection. Thank you.